This case history was based on a question from a medical residency exam.
Male 65, sudden severe chest pain radiating to the back, diaphoretic near syncope.
BP's fluctuating. Pulses feel different side to side. Estimated time of arrival, 2 minutes.
It hurts. My chest. It's crushing. Can't breathe.
Hang in there, sir. We're almost there.
Please, paramedic, give me the rundown. When did the pain start? Any trauma?
10 minutes ago, sudden onset, no trauma. Blood pressure all over the place, pulses are off.
Doctor, oxygen and monitors ready. Let's check your oxygen, sir. Try to relax your hand for me.
It's so cold.
Nurse, please start him on high-flow oxygen. Let's get full vitals and a 12-lead ECG.
On it. Oxygen going up.
Doctor, he almost passed out in the ambulance. Watch for another drop.
Let's check both arms. His pulses felt off.
Now, we will check in the other arm. Good call. Watch for a big difference.
What's the story? I heard chest pain and pulses off. What's our working diagnosis?
Acute chest pain radiating to the back, hypotensive episodes. We're getting full vitals now.
It's getting worse. Feels like it's tearing.
Stay with us, Mr. Sato. We're working fast.
All, let's move. Nakahara, start your exam. Nurse Emmy, get IV access and labs. Paramedic, any allergies or meds?
No allergies, just hypertension meds. Family's on the way.
Left pulse is strong, right is barely there. That's not good.
Sir, please, deep breath in and out. Any pain when you breathe?
Hurts all the time, not just when I breathe.
Just a little pressure, Mr. Sato. This will help us get you some relief. Doctor, IV access secured. 18 gauge.
Dr. Akiyama, got the portable ultrasound just as you asked.
Good, Kato. Just try not to take out any nurses on your way.
Just a few more seconds, Mr. Sato. This will give us a better picture of your heart. Pain radiating to the back, asymmetric pulses. But what about the ECG?
The ECG isn't showing a clear STEMI, but those pulses and the pain. Something isn't adding up for a typical myocardial infarction. All right, team, let's consolidate. Nakahara, what's the ECG showing? Nurse Emmy, any initial lab results?
ECG shows sinus tachycardia, no clear ST elevation, but some non-specific T-wave changes in inferior leads.
Labs are still processing, Dr. Akiyama. IV fluids running.
Mr. Sato, can you tell me more about this pain? Is it constant? Does anything make it better or worse?
Constant, like a tearing in my chest, goes through to my back. Nothing helps. Just dizzy.
BP's 90-60, and then 140-80 on the other arm. That pulse differential is significant.
Saturation is holding at 96% on 4 liters, but his respiratory rate is 24.
Heart sounds are muffled, no obvious murmurs, but that carotid pulse feels weak.
Dr. Nakahara, any rubs, gallops? What about lung sounds?
Doctor, nothing abnormal, no rubs, no gallops. Heart's regular, lungs are clear.
Mr. Sato, any history of heart problems, high blood pressure, diabetes?
Hypertension for years, on medication, but sometimes I forget.
Hypertension, non-compliant, noted.
Still asymmetric, Dr. Akiyama. The right arm is consistently lower by almost 40 millimeters of mercury.
That's a critical sign. Keep an eye on it.
Just a quick blood draw, Mr. Sato. We'll get answers soon. Dr. Akiyama, samples for troponin, D-dimer, and complete blood count are on their way.
No ST elevation, but these T waves are odd. Doesn't fit the classic MI pattern.
Let's not anchor on MI just yet. Keep thinking.
See Dr. Akiyama. No clear STEMI. Could it be a NSTEMI? Or maybe just unstable angina?
Possible. But the pain quality, the radiation to the back, and especially those asymmetric pulses, that's not typical for an MI alone.
So, not a heart attack?
Please nurse aspirin 300 milligrams chewable. And let's get a nitro spray ready, but hold for my go-ahead.
Aspirin coming up. Nitro spray ready, sublingual.
Mr. Sato, we're giving you some medication to help your heart. Just chew this for me. Hold the nitro, nurse. His BP is still fluctuating wildly, and that pain quality. I'm worried about something else.
Understood, Dr. Akiyama.
Kato Nakahara, let's get a quick look at the aorta. Parasternal long axis first. Look for any dilation, any flap.
Yes, Dr. Akiyama. Gel applied.
Steady, Kato. Angle slightly medial. There. Now sweep.
Dr. Nakahara, is that normal?
No, that's not normal. Dr. Akiyama, take a look at this.
Aortic root, irregular, pulse deficit, herring pain. This isn't a heart attack. It's something far more dangerous. This isn't an MI. We need a CT angiogram stat. Nakahara, call radiology. Tell them we're coming with a suspected aortic dissection. Nurse Emmy, prep for rapid fluid bolus if his pressure drops further.
On it, Dr. Akiyama.
Fluids ready.
Aortic dissection, wow.
This is it. The real battle begins now. We can't afford to be wrong.
Dr. Akiyama, could this be a massive pulmonary embolism? Sudden chest pain, hypotension, and he's tachycardic.
P is possible, but the pain radiating to the back and those asymmetric pulses don't fit. Plus, no signs of DVT or risk factors.
Could it be pericarditis? I read that can cause chest pain too.
Good thought, Kato. But pericarditis pain usually gets better when sitting up, and we'd expect a friction rub. Plus, no pulse deficit. The D-dimer will tell us more about P. But the clinical picture just isn't screaming embolism. And the ECG doesn't show the diffuse ST elevation we'd expect with pericarditis.
So, if it's not MI, not PE, not pericarditis, what else causes this kind of pain and pulse discrepancy?
His pressure is dropping again, Dr. Akiyama. 85/50.
Tearing pain, radiating to the back, asymmetric pulses, hypotension. To be the classic presentation. Why didn't I see it clearly before? Start the scan. Focus on the aorta from the arch down.
Just a few more minutes, Mr. Sato. Try to hold still.
This is it, the moment of truth.
There it is, type A aortic dissection, just as I suspected.
Unbelievable. The flap is clear as day.
Wow, so that's what it looks like.
His is Dr. Akiyama, emergency department. We have a 65-year-old male with a confirmed type A aortic dissection. We need immediate surgical consult and OR prep. BP is labile, pain is severe.
Amy, start with labetalol. We need to get his heart rate and BP down fast. Then nicardipine if needed.
Labetalol drawing up now.
Control heart rate and blood pressure. Reduce shear stress.
Medication infusing. Heart rate dropping. BP stabilizing at 110/70.
Pain seems to be easing too.
You're doing great, Mr. Sato. We're getting you stable. Classic aortic dissection. Tearing chest pain, pulse deficit, hypotension. The key was not anchoring on MI and thinking broader.
The pulse difference was the clue. I'll never forget that.
So much to learn, but this is why I love medicine.
Thank you, all of you. I thought I was done for.
You're safe now, Mr. Sato. We'll get you to surgery soon. Another one saved. Good work, everyone. That's why we always keep an open mind.
Definitely a case for the books. I learned a lot today.
Aortic dissection, the great mimicker. I need to study more.
Time for a well-deserved break, I think.
In the relentless world of emergency medicine, every case is a lesson. What new challenge awaits our team tomorrow?